Next, we go to Dr.
Thank you for the ATMO organization for invitation, and I will speak to you about a case of a little girl, 4 years old age, who was referred to our department for congenital left eye deviation. She had neither consanguinity nor pathological past medical history, and her best visual acuity was 4 up to 10 in right eye. And we notice in the left eye amblyopia signs such as esotropia and hypertropia related to unilateral microphthalmia. Ocular examination found a bilateral inferior iridal coloboma, and in the vast examination we noticed bilateral inferior retinal coloboma involved with the macula in the left eye. So what is this entity, please? This ocular entity is microphthalmia, ophthalmia, and coloboma, which comprise the max spectrum of ocular malformation. For you, is this entity require further investigation? Obviously yes, because an associated systemic abnormality is identified in more than 30% of cases. So, for each patient, we have to do an ophthalmological examination by an ophthalmologist familiar with MAC syndrome to document both the ocular manifestation of MAC and any additional other ocular findings. Ocular and brain imaging must be done. Physical examination included dental evaluation, echocardiogram, renal ultrasound examination, a family history to obtain a 3-generation family history, and finally a genomic and genetic test. For our patient, the general examination found a facial dysmorphia, including a flat nasal bridge, flared nostrils, and close-set ears. Hand examination found in a right hand syndactyly of the 5th finger, and in the left hand the syndactyly of the 3rd and 4th fingers, and associated to syndactyly of the 5th finger. We also notice the syndactyly of the 2nd and the 3rd toes of the left foot. Dermatologic examination found hypopigmented lesions, was biopsied, and skin biopsy found suspicious lesions of incontinencia pigmenti in histology examination. Abdominal ultrasonography found in the left side 2 small kidneys joined by a parenchymal bridge. And the echography and G-banded karyotype analysis were normal. So at what diagnosis must we think in front of eye, limb, and skin association? It becomes a little bit complicated, but we can be helped by some books and some internet sites like Orphanet, and 3 diagnoses were most frequent, such as incontinencia pigmenti, because the patient presented suspicious lesions of incontinencia pigmenti, the GOD syndrome, and the acromelic syndrome. We will talk about it. For dermatologists, GOD syndrome was most probable in front of the skin atrophy area. The ocular involvement type of iris coloboma, microphthalmia, and strabismus, skeletal involvement such as syndactyly and aplastic fingers and toes. The gene is unknown for this malady, for this pathology, but some authors have described patients' GOD syndrome having a deletion of the short arm of the X. But in our patient, G-banded karyotype analysis was normal, and we didn't find this breaking point. So now we are looking for an ophthalmoacromelic syndrome with a geneticist. which is a rare syndrome comprising eye malformation and lip anomalies. Other systemic disorders can be associated, such as renal, vertebral, vascular malformation, as well as mental retardation, but no associated incontinence pigmenti have been reported until today. Molecular genetic study is ongoing for our patients. So if we have to take a home message, is to always look for systematic abnormalities in case of microphthalmia and coloboma, because there are numerous associations and phenotypes requiring multidisciplinary collaboration, and genetic and molecular tests are necessary because they lead to mutational screening in 80% of cases and to better classify the spectrum of malformations. Thank you.
Diabetic retinopathy.
Thank you very much. It's a case about Mrs. H. She's a 61-year-old female with medical history of diabetes mellitus for 15 years and hypertension. She came for diabetic retinopathy screening. On examination, she had abnormal visual acuity of both eyes, pupil extraocular motility, as well as sacral examination were unremarkable. As you can see on fundus, there are many blood hemorrhage on the far border of both eyes. So angiography was performed, and we found a severe non-proliferative diabetic retinopathy on the right eye. As for the left eye, we found proliferative diabetic retinopathy. So we started upon retinal photocoagulation on both eyes. 4 months later, she came with a complete retinal detachment on the left eye, and on the right eye, you can see that there are many round, dark, large hemorrhage of the posterior pole, some flame-shaped hemorrhage, and veins slightly dilated and tortuous, especially on the inferior veins. Somebody can see another sign. Do you see another sign? The white-centered hemorrhage. We suspected, first of all, a retinal vein occlusion. So we did an angiography and a routine workup. But the angiography did not show any retinal vein delay. But the count of blood cells showed hemoglobin at 8, white blood cells at 1,500, and platelets at 30,000 cells, and most of all, blood blast at 40%. Bone marrow biopsy showed acute myeloid leukemia. As the disease was very advanced, the hematologist decided targeted chemotherapy. The evolution was for the right eye, visual acuity, no light perception, upward pupillary defect, and dense intravitreal hemorrhage without retinal detachment on the echography. The left eye showed visual acuity that was limited to light perception. And on the MRI, there was a probable optic nerve infiltration of the right eye. The conclusion is that the patient may present with retinal pathology mimicking diabetic retinopathy, and it is necessary to consider other etiologies in the differential diagnosis. Some of these etiologies are frequent, such as hypertensive retinopathy, vascular occlusive diseases, and others are less frequent, such as infectious diseases, cancer, and paraneoplastic diseases. Thank you very much.
I think Dr. Fadri has a question. No?
Wait. I would like just to thank Snipers for this first time in this English session. And
Yes.
2 years ago, Snipers asked me if there is an idea to move with the language of the proper language, and I didn't give him an idea that with the new concept and
Close to the microphone. Close to the microphone.
yeah, and we. So congratulations for the level of the young English speaker.
Thank you, Dr. Bradley. After this tough experience for some of you, including myself, I am pleased with the level of the English pronunciation for our young residents. And it's helpful for us to fix this session at the next Congress. Thank you very much.
And congratulations, because you finished before the time, on time or before the time. It's very nice.
This session is end. We hope that it was interesting and successful. We thank again the ATMO and all the participants of this session, and we hope there will be many others, and we wish you an enjoyable meeting.